Over the last years, that has been summarized in a meta-analysis that we performed last year, the concurrence between two of the most common sleep disorders, namely obstructive sleep apnea and restless leg syndrome, has been the concurrence of the two has been the comorbidity of the two has been well established. Out of the total, out of every 100 patients suffering from OSA, approximately between 20 and 32, depending on the different case series, on the different studies, suffer from concomitant RLS. What happens when RLS is occurring in a patient that simultaneously suffers from obstructive sleep apnea? Well, usually the presence of RLS leads to an increase in severity of RLS itself. Those patients are usually, in terms of RLS symptoms, more severe, but also the OSA symptoms are more severe. So there is a mutual reinforcement in the worst sense of the word, in the sense that both disorders become more severe. Um, eh, well, not only that, there is also a fraction, a group of patients that for which the RLS is so severe that their tolerance towards CPAP is lower. They cannot just tolerate CPAP, and for that reason, their OSA gets untreated in a not negligible proportion of patients. This is the other consequence of that. But in general, both disorders become more severe. We are showing data at this meeting by which we ask ourselves, what's the reason for the increase comorbidity between the two? Why is that association taking place? We come to the conclusion that patients with comorbid OSA plus RLS have lower brain iron levels than patients with OSA, just OSA. And their brain iron levels are similar to those patients with just RLS. So, in other words, those patients with OSA in which, for whatever reason, the brain iron levels decrease. I'm talking not so much about the serum iron levels, which are usually very similar to the general population, but brain iron levels. Whenever these brain iron levels decrease, if they have other genetic factors, etc., they will develop RLS. And that is one of the reasons for the increased comorbidity. But there are also several mechanisms that play in the same direction. The chronic inflammation that takes place as a natural thing in OSA uh, tends to mask the serum iron levels in RLS patients. So they misguide the clinician in some way because they artificially increase the ferritin levels. They falsely increase the ferritin levels, making the clinician believe that the serum iron levels are normal when they are not. When they are not. So there is an interplay between hypoxia, inflammation, and decreased brain iron that leads to that comorbidity. What we recommend in these cases? Well, first of all, a good diagnosis, being able to identify both conditions. RLS patients can, this is a message mainly to the RLS community, RLS patients can have other sleep disorders than RLS. So that would be a rationale to look into to perform a sleep study on those patients. That would be a very strong rationale to do that. But also to the sleep disordered breathing community, that when OSA patients have, I would say in general, whenever you see that an OSA patient has a decreased sleep efficiency, you should ask yourself and do a differential diagnosis for RLS. Okay, good diagnosis is always the first step. But on top of that, when it comes to treatment, I would start with an aggressive um, iron treatment on of these patients because it will for two reasons because it's very likely the the cause of the RLS, and secondly because if you treat the iron condition, it will take a while until things resolve. So the sooner you start, the better. In other words, no. Um, okay, once that has been done, I would consider an aggressive treatment of the OSA because if you are able to eliminate the hypoxia factor, the normoxia, I mean the normalized oxygen levels are going to secondarily reduce the chronic inflammatory factors that are leading indirectly to the RLS. So start treating first the iron condition. Secondly, right after, I would treat the OSA. And if the patient does not tolerate, for patients that do not tolerate um, the CPAP because of the severity of their RLS symptoms, of course, you can always try a short-term pharmacological management of the RLS symptoms that will calm them down during the night and that will give you the opportunity to start with the CPAP treatment.